What's the time? Okay.
Recording in progress.
Shani.
We are live.
Shani.
A very good evening to all. I cordially welcome you to our first module of Pulmocare Sky series. And it's an initiation by Institute of Pulmocare and Research. I would like to invite Dr. Parthasarathi Bhattacharya to proceed over the session. I welcome you, sir.
Good evening. Welcome to you all. Myself is Dr. Parthasarathi Bhattacharya. I'm a consultant of the Institute of Pulmocare and Research, Kolkata. Let me say a few words about our institute, about our initiative, and about today's topic. Our institute is a non-profit organization meant to go for research, education, and patient care. And it has been 21st year running. And we have moved quite a bit in these last 20 years. We are trying to serve our motto as best as possible. Regarding this particular program, we have been interested in education. We have got a formal conference called Pulmocon, which is continued for last 19 years. And from 12th of next September, means next month, we are going to have our Pulmocon 2021, which will be online and in which there will be many interesting topics and facets related to pulmonary medicine and the practice of pulmonary medicine. I would request others to mute their phones, mute their mics. Okay. Coming back to our initiative of postgraduate education, we have been doing this intermittently. But this time we thought that we should go on a series of postgraduate classes. And these classes may not be necessarily dialectic lectures, but interestingly, somehow it started with COPD. And there is as such no reason to start with COPD. It is just coincidental. And the Sky, the very word, means skill, knowledge for youngsters. So we want to impart skill and knowledge to our youngsters. This is though meant for postgraduate students, but this is meant for everybody. We would be trying to be as simple as possible. And we thought that for all the classes, all the postgraduate classes, we'll start from the very basics. We'll discuss the basic physiology, anatomy. Then we'll discuss how the physiology is converted into pathology, how there is a pathogenesis of a disease, and how ultimately a disease manifests. If you ask for COPD, it's a huge chapter. 20 years back, 24 years back, when I passed out my postdoctoral fellowship, COPD was not this much. Now COPD is huge. It's like a big book. And as you move into COPD, you find so many interesting areas, so many domains. Everyone is expanding. Every domain is saying, I am myself, look at me. As if everyone is rest and calling you, attracting you to it, so that you read him or her and try to understand what he or she is going to speak about a patient of COPD. The COPD, it is no longer a pulmonary disease, it's a systemic disease. And it has actually engrossed many other subspecialties by virtue of its presence in the body. The complications of COPD, the comorbidities of COPD, everything together makes a whole gamut of problems that comes to us every morning and evening. And we have got a huge number of COPD sufferers in this country. So it's very high time that we should learn COPD, we should treat COPD, and we should focus our attention to COPD research. This is a very fertile area because in this country of 140 crores, there is a huge number of COPD. I'm not going to discuss about epidemiology of COPD. Giving statistics, numbers, curves, charts, they actually burden the heads, minds, and ultimately sometimes distracts people from the basic learning. So we thought that we should place them as and when required, but we should try to give the very basic concept first, and we'll build up on that each of our topic. For today, we have got two parts in our first Sky program. The first part will be taken care by Dr. Arindam Mukherjee. Dr. Arindam Mukherjee is a newcomer to Kolkata. He has completed his DM pulmonary medicine from PGI and has been in Kolkata for last 2 years or so. He has been trying to establish himself as an independent pulmonologist, and he's attached to Tata Medical Center, Cancer Hospital and Research Center now, and also he's attached to Institute of Pulmocare and Research part-time. So Dr. Arindam Mukherjee has got a very strong aptitude for clinical medicine and clinical pulmonology, and I have found that he loves treating COPD patients so well. So we decided, let us play between ourselves. And when I told Dr. Arindam, he immediately agreed. He said that I'll be taking care of the anatomy and physiology part of it. I was very happy to learn that this basic is almost always neglected. And COPD is such a disease where it is very, very important to understand the basic pathophysiology. And I'm sure that it will be very, very enlightening from Arindam Mukherjee. And after Arindam finishes, I will take up what a physician should know in making a diagnosis. So it seems the diagnosis is very small. It's nothing big. You do look at the patient, see his symptoms, and just write down COPD as we always do, and we finish our job. But when I thought that I will speak about COPD diagnosis, what a doctor should know and do, it somehow expanded in my mind. Well, I will try it later on. For now, let me welcome Dr. Mukherjee. Dr. Arindam Mukherjee, please, for your kind deliberations. Arindam, please. Arindam, please.
Sir,
please unmute yourself. Unmute yourself. Unmute yourself. This is a problem of unmute. Not you are muted. You are please unmute. অরিন্দমকে শোনা যাচ্ছে?
না, উনি এখন আনমিউট করেছেন। একটু ভলিউমটা আপনি বাড়িয়ে নিন আপনার অডিওর।
Arindam, carry on. I cannot listen to him.
স্যার, আপনি একটু ভলিউমটা অডিওর বাড়িয়ে নিন।
আমার ভলিউম?
না না, অরিন্দম স্যার উনি আনমিউট করেছেন কিন্তু সামহাও শোনা যাচ্ছে না।
Abhijit, please take care.
I think this is the device problem.
একটু তোর ভলিউমটা বাড়াতে কিছু করা যায় কিনা দেখতে। আচ্ছা, volume is in full volume. Abhijit, can you see the problem?
Yeah, sure. Sir.
Hello? ঠিক আছে।
Hello.
আচ্ছা, tell him to log out and join. And start afresh. Start with me. জয়েন কর, আবার নতুন করে শুরু করবো আমাকে দিয়ে। ঠিক আছে, শায়নি আমাকে দিয়ে স্টার্ট করবি আবার। জাস্ট তুই আই ওয়েলকাম ডক্টর ভট্টাচার্য, ব্যাস আমি এক লাইন কথা বলে ওকে দেবো, তাহলে রেকর্ডিং হবে না। Thank you for the kind introduction. Welcome. We are already going about 10 minutes behind the schedule for the technological glitch. So first Sky program, it is my pleasure duty to introduce Dr. Arindam Mukherjee. our consultant pulmonologist, to talk about the anatomy and physiology of COPD. Dr. Arindam Mukherjee, please. Arindam, please. আমি শুনতে পাচ্ছি না. Go on, carry on. Okay, carry on. তাহলে তুই ওদের সাথে কথা বল, আমি আমারটা চালু করে দিই. অভিজিৎ, can you hear me? অভিজিৎ,
Yes, sir, I am hearing you.
হ্যাঁ, তো দেখে বল আবার নতুন করে স্টার্ট করতে, আমাকে দিয়ে চালু করে দিতে. শাহানিকে বলতে হবে না, একদম নতুন করে স্টার্ট করে দিতে বল, আবার ফ্রেশ. Hello, may I start? অভিজিৎ শুনতে পাচ্ছিস? অভিজিৎ শুনতে পাচ্ছিস? হ্যালো সায়নী, শুনতে পাচ্ছিস?
হ্যাঁ স্যার, শুনতে পাচ্ছি। আপনি
অভিজিৎ
স্টার্ট
কি
করে
করছে? আমি শুরু করে দেবো, ঠিক আছে. এখান থেকে রেকর্ডিং হবে. So thank you very much for the introduction. It is my pleasure again to talk about the what a doctor should know and look for diagnosis of COPD. So let me upload my talk. Arindam is also trying, it seems. শায়নী কি হলো? অরিন্দম কি চেষ্টা করছে আবার? শায়নী, অরিন্দম কি চেষ্টা করছে আবার? মাঝখানে আমি আপলোড করতে গিয়ে দেখলাম অরিন্দম এসে গেল.
অরিন্দম স্যার এখন তো নেই স্যার পার্টিসিপেন্ট লিস্টে, বোধহয় বেরিয়ে
তাহলে আমি ঢোকার চেষ্টা করি.
হ্যাঁ স্যার, আপনি শেয়ার করুন.
I'm trying to enter. There is some problem with the system. It's going too slow.
স্যার আপনি শেয়ার করছেন?
I'm trying, it's going too slow. শেয়ার হচ্ছে না.
Recording stopped.
Hello? Hello?
Yes,
এখন
sir.
কি আমি audible?
Yes, sir.
Sir, you're audible, sir. You're audible. You're audible, sir.
হ্যাঁ, তো আমাকে একটা শেয়ার স্ক্রিন অপশনটা কি আমার কাছে আছে এখন?
Arindam, please start.
হ্যালো?
Please start.
You're audible.
স্টার্ট করতে পারছি না।
Recording in progress.
আপনি করে দিয়েছেন? আপনি স্টার্ট করে দিয়েছেন, আমি চেষ্টা করে দেখছি যদি করা যায়।
I can listen to you. You can start it now.
না স্যার, আমি না এখান থেকে ওই শেয়ার স্ক্রিন করতে পারছি না, শেয়ার স্ক্রিনের অপশন আসছে না।
Oh, same problem I had. Okay, Arindam, Arindam has some problem to share the screen. So I am starting. I think this Zoom has some problem. I had to stop once for this.
Sir, if you can click on the mobile icon, the green button is below that.
হ্যাঁ, বলো বলো।
একবার স্যার মোবাইলের স্ক্রিনে টাচ করলে একটা গ্রিন বটন আসছে মাঝখানে তলার দিকে।
মিটিং
আপনি
আছে
একবার টাচ করুন।
আপনি এসএমএস করেছেন?
শেয়ারে টাচ করব?
হ্যাঁ, শেয়ারে।
স্যারকে করতে বলুন, আমি চেষ্টা করছি করার।
শেয়ারে টাচ করে স্ক্রিনে টাচ করতে হবে, সেটা তলার দিকে স্ক্রল করে স্ক্রিনে টাচ করতে হবে। স্ক্রিন বলে একটা অপশন আছে।
আমি বুঝেছি, আমার পাওয়ার পয়েন্টটা খুলছে না, আমি চেষ্টা করছি খোলার, আপনি স্যারকে স্টার্ট করতে বলুন।
ওকে।
ঠিক আমি করছি, কিন্তু আমারটাও খুলছিল না। আমি অনেক সময় ধরে চেষ্টা করছি তখন।
Recording stopped.
this technological glitches, I couldn't get in, and we failed to listen to Dr. Arindam Mukherjee, who was supposed to talk about the anatomy and physiology of COPD. So my talk is regarding diagnosis, what a doctor should know and look for. The basic anatomy and physiology, I just skip it for the time being away. I'm not going into the details of anatomy and physiology. Let me straight away come to a small cartoon. This is a small lung. The alveoli actually represents a lung, and the pipe which is attached to it is the airways. So actually the lung is nothing but multiple alveoli been communicated to the environment through airways. So this is oversimplistic presentation of the lung. And if we inspire this, what happens within the thorax? So because the lungs expand, the intrathoracic airways are pulled away. Their walls are pulled outside. So the lumen increases in diameter and the air gets in easily. So this is the inspiration. When the patient expires, the opposite happens. Actually, there is a pressure built up outside the airway wall, and actually it squeezes the airway. If that pressure is more than the intraluminal pressure of the airway, then the airways might block also. So this also happens in COPD. There is a concept of end pressure point. It was supposed to be told by Dr. Arindam. However, I'm not going into details of it, but I mean to say that intrathoracic airway lumen actually is dynamic. Part of it is cartilaginous supported, and the part of it is non-cartilaginous. The non-cartilaginous part actually is more prone to this change of diameter in inspiration and expiration. Smaller bronchioles are far more prone to be collapsed on expiration. Well, COPD, as we all understand, chronic obstructive pulmonary disease. So there is obstruction of the airways. And you can see in this cartoon, the normal is thin airway wall. Here the airway wall has turned thick. So there is airway wall thickening. And COPD is a disease of airflow limitation or airflow obstruction. There are three things happening together. One is thickening. This thickening could be because of the mucosal hypertrophy, mucosic, or there will be extra mucosal, the muscularis, or the other structure of the airway wall that hypertrophy and make the airway wall thicker. So as the airway wall turns thick, as there is mucus secretion, there is narrowing of the airway. And this narrowing actually leads to airflow limitations. If this narrowing and thickening continues, there is stiffening, and that is called remodeling of the airways. So there are three things as narrowing, thickening, and stiffening of the airways. Narrowing and thickening are structural, and stiffening is also structural, but it's more or less permanent. So COPD is a disease of resistance to airflow, secondary to obstruction and loss of reversibility. Let me come to the basic physiology a little. Here you can see this is there in every textbook, every basic book, primary book of respiratory medicine and physiology. This is tidal volume. Right now I am breathing up and down in this zone. This is about 500 ml. But let me start a deep breath and just go as much as I can. I have reached here and then blow it out and I go reach at the bottom. So the difference between the maximum inspiration to maximum exhalation, it is a vital capacity. This is a vital capacity. And it is divided into three parts. The tidal breathing or the tidal volume, inspiratory reserve volume, the air I can take extra on top of my tidal volume, and the expiratory reserve volume, the air I can exhale extra at the bottom, from the bottom of the tidal volume. So expiratory reserve volume, inspiratory reserve volume, and tidal volume, they all together make the vital capacity. But whatever I try, at the end of my exhalation, some air will remain in the lungs, and that's it. That is the residual volume. And this residual volume I cannot utilize. If I add residual volume to vital capacity, it forms a total lung capacity. So this is the total lung capacity, and this is vital capacity. This bit of physiology is known to everyone. I don't want to speak more about it. But see what happens in COPD. In COPD, because of narrowing of the airways, there is obstruction to airflow. And this obstruction is more in exhalation. And if there is airflow obstruction more in exhalation, And if by chance the whole of the tidal air which has been in is not being exhaled out, there will be some air left out, which is called stacking. So in this particular left-hand side, you can see the normal status where the residual volume is small. This is the residual volume. But here you can see as you move on, there is air trapping, and with each breath, or each breath maybe, and that residual volume increases because the air breathed in cannot be totally exhaled out. So after some time, there is a bit of extra air. The residual volume has increased at the cost of vital capacity. Here again, the residual volume has further increased at the cost of vital capacity. And this is RV3, maybe after a few minutes, the residual volume is further increased at the cost of vital capacity. So as there is more and more narrowing, after a critical narrowing level, the exhalation is incomplete. Some air is left out, and that left out air, which each breath actually builds up, it stacks up one after another and makes air stacking. So this is the physiology of air stacking. If you want to understand air stacking and physically feel it, I would request you to take a deep breath and hold. Then try to breathe again on top of this and hold. Then try to breathe again and hold. This is the feeling the patients of COPD have, and they express that they cannot take breath. They have got kind of shortness of breath, sometimes as if, and if you make a full breath and on top of that you try to breathe in, you can understand the difficulty. This is the feeling of the COPD patients. So impact of this airflow obstruction is that there is air stacking gradually. At one point of time, airflow obstruction impedes expiration more than inspiration. There is incomplete expiration, leaving some extra air within. Serially and gradually, that extra, quote unquote, air increases in volume, increasing the residual volume, which I've already told that doesn't play in part of gas exchange. So there is increased residual volume, and that is useless as a part of our ventilation effort. Air stacking increases with increase of residual volume at the cost of vital capacity. Now come to this situation. Normal versus airflow obstruction. In normal breathing, see, inspiration expiration is almost equal. Well, the ratio is say 1. This is a hypothetical situation. The expiration is not prolonged because there is no obstruction. Sometimes expiration is even shorter than inspiration. But in airflow obstruction, as the obstruction increases, the expiration becomes more prolonged in order to exhale out the inhaled air. So here, inhalation is 1 second and exhalation is 2 seconds. So each respiratory cycle takes 3 seconds. And the ratio of inspiration is to expiration is 1:2. Here, the inhalation is 1 second and the exhalation is 3 seconds. This is far more obstruction, and at 2.5 seconds, and you can see it is 1:2.5. So you have to allow here 3 seconds for a respiratory cycle, and you have to allow here 3.5 seconds, 1 plus 2.5. If it is 3 seconds per cycle in a 60-second time for a minute, you can have 20 breaths. But here, you cannot have 20 breaths. You have to have less breath rate in order to exhale the whole air. But what happens in real world, in real life, if there is airflow limitation, airflow obstruction, there is less ventilation, there is hypoxemia, there is hypercapnia, there could be hypercapnia. Actually, demand for respiration is more, the breath respiratory rate in fact increases. And that actually reduces the respiratory cycle. So at the end of each expiration, some air is trapped and air stacking starts in. So this is what is again shown in nutshell. That reduced vital capacity means reduced exercise capacity. Patient may be quite normal at rest, but as he exercises, the demand increases for oxygen. So there is increased respiratory rate, there is increased air stacking, there is increased intrinsic PEEP. If I will explain intrinsic PEEP later on, and that increased air stacking actually increases the dyspnea. So dyspnea is related to air stacking. Dyspnea is not related to FEV1. We have an idea that FEV1, low FEV1 is a cause of or obstruction, the obstructive marker. FEV1 is a marker of the level of degree of obstruction. The degree of obstruction is most important for dyspnea. Yes, it is related to air stacking, but it is not one-to-one relationship. But if there is air trapping, there will be dyspnea. This is a normal situation, inspiration and expiration. You can see this is the inspiratory air within the thorax, this is expiration, and this green block of air is added to inspiration. And the diaphragm domes is up, high up, there is a zone of apposition, and this diaphragm can be pushed quite low, and this movement of diaphragm actually draws air in from the environment. So this is normal, and this is a situation. This is normal, and if I come to COPD, the lungs are already hyperinflated. Transversely, the diameter looks a little more. Longitudinal diameter is increased. The diaphragm is not that high up. It is much lower at inspiration. And once it expires, then it becomes almost flat. So there is a flattening of diaphragm. The flattening is here also, but it is less, but it is more obvious in expiration. But as the disease progresses, the diaphragm gets more and more flattened in inspiration. And that means what? That means a mechanical disadvantage for the diaphragm to go down. This is the main piston in the cylinder. Chest is a cylinder, diaphragm is a piston. The piston moves and gets the air in, but if the piston cannot move, the air entry is reduced. So less air entry because of the mechanical disadvantage out of hyperinflation of the lungs in COPD. And this leads to hypoventilation in COPD. So this is a basic physiology where the COPD people differs from norm. The same thing been shown. The lung volume is increased here, but actually the ventilation is reduced. If you can see the lung volume in COPD, it is increased both in inspiration and expiration. This is inspiration versus inspiration. This is expiration versus expiration. But if you see the ventilation, amount of ventilation is reduced. And this shows that the inspiratory reserve volume is reduced, the expiratory reserve volume is reduced, and you can see the residual volume is increased. So I told that vital capacity is reduced at the cost of increased residual volume. The vital capacity consists of inspiratory reserve volume, expiratory reserve volume, and tidal volume. So both these reserve volumes are reduced, sometimes at the very advanced stage, the tidal volume also. So what a doctor should know about and look for: exercise capacity is reduced in COPD. The patients are perfectly all right at rest, but they will complain that they have got shortness of breath on exercise. The classical story goes like, doctor, I used to catch my train, even running for a distance of 100 meters 10 years back. Gradually, my capacity came down. I started walking briskly. Then my pace went down. Then I had to take long time to reach the station, which is quite near to my house. And nowadays, I have to take a rickshaw to go to the station. So his exercise capacity is reduced. He's accommodating himself with the reduced exercise capacity. And he says that I'm okay, doctor, I have got no problem. This is how COPD patients accommodate, and they do not understand that they are suffering from a serious disease. And once they come and seek help, they are quite advanced. Exercise leads to air trapping, which I've already explained. Dyspnea in COPD is related to air trapping or hyperinflations, not the lung function reduction. Classically, perception of dyspnea is individual specific. This is another very interesting area. That dyspnea is absolutely individual. We'll come to it later on. And reduction of air stacking may be beneficial once the residual volume is reset to a low level. If the residual volume is increased, there is hyperinflation. If you can reduce the residual volume, the hyperinflation will go, the diaphragm will get its previous original shape, the domes will be up, and with inspiration, it will go down, it will bring in air within, it will be leading to good ventilation and good air exchange, oxygen exchange, and there'll be good oxygenation of the blood. So reduction of the residual volume is very important. And that's what we do, even in our clinical practice, with medications, with rehabilitations with respiratory or breathing exercises. If you increase your exhalation by any means, you will allow more air to be exhaled out. So we call that you slowly breathe out. We say you do partially breathing. The patient automatically, spontaneously start that. So this is a basic physiology. So a doctor should know this bit of physiology. So while you understand the physiology, let me come to the etiology. American Lung Association lists all this as a etiology. Smoking, exposure to air pollution, breathing secondhand smoke, environmental tobacco smoke, working with chemicals, dust and fumes, a genetic conditions called alpha-1 antitrypsin deficiency, a history of childhood respiratory infection. So that's okay, but is there anything missing for us? Yes, it is a biomass smoke exposure. This is very, very important in our country and almost in the rest of the developing world. Probably the biomass smoke induced COPD is far more frequent than smoking. But I have kept in the second position, although I made it bold, to impress you that this is a very important entity and this is what we should also be taking care of. And from now onwards, any respiratory physician who has been listening to me should understand that he or she has to take the history of biomass smoke exposure. Understanding symptoms and signs includes history of progressive symptoms to be incorporated. Poor reversibility means the symptoms are fairly persistent and not totally recovered in between. There could be intermittent exacerbations, and the etiological factors are to be taken into account. What should a doctor look for in a patient of COPD? As a patient walks in, look at the patient, look at the appearance. I'll speak about the appearance, I will not detail everything. Look how he or she is breathing. Are the muscles, accessory muscles of the neck, the sternomaster, are they prominent? Can you see there is suprasternal suction in inspiration? These are all visible as the patient gets in. How does he keep his hands? Is his shoulders a bit up? Is the chest looks barrel-shaped? What is the respiratory rate? Is there paradoxical breathing? These are all features of essentially air stacking or hyperinflations. The paradoxical breathing is pretty common, but I have found that people do not take care of this particular issue. Even they don't bother to look at. If you see the patient is bulging the abdomen in exhalation, that is paradoxical breathing. What happens in inspiration? The abdomen goes in and the chest below, it actually swells. And in expiration, the abdomen goes, the abdomen is also bulged. And in expiration, the abdomen goes in. But here you can see the patients are bulging the abdomen in expiration, and the abdomen is going in inspiration, which is just the reverse. This paradoxical breathing is a sign of advanced COPD, is a sign of air trapping. And if you can correct this by respiratory breathing exercise, physiotherapy or other, if you can correct it, the patient will get immediately a lot of relief. So that is a part of therapeutic exercise, non-pharmacological, to correct the breathing pattern. Well, these are features of air stacking. So a doctor should look for features of air stacking. If a patient has got expectoration, the history will be forthcoming. The patient will be coughing, and if the patient coming to you is looking a little drowsy, he's brought in a wheelchair, he looks dull, he looks cyanotic, then these are features of hypersecretion and dull CNS response. What I told, the respiratory response is individual. So some people, for reason unknown, they have got a dull CNS center, respiratory center, and some people have got active respiratory center. Those who have got active respiratory centers, they breathe frequently, they try to ventilate well and try to exhale carbon dioxide out from the system. But those who have got a dull breathing respiratory center, they're not responsive to the raised carbon dioxide level in the blood. So as the carbon dioxide builds up, they don't bother, their respiratory rate doesn't go up. So they hold carbon dioxide, they retain carbon dioxide, and as a result, they turn cyanotic. Pallor is common in COPD because COPD is an inflammatory disease. I've not gotten into the pathology, and not the polycythemia or erythrocytosis. It is not polycythemia, erythrocytosis. But COPD-induced erythrocytosis more common if there is a prolonged hypoxemia in COPD, which is frequent when there is associated obstructive sleep apnea or similar condition with COPD. So if you find a patient of COPD having erythrocytosis or features of suffused conjunctiva, think of that he or she may have OSA or kind of hypoventilation. Clubbing is not common, or clubbing is not known in COPD. So if there is clubbing in COPD, it's very important. It's negative. There is something but COPD. There is something else with COPD. So we must look for something that can cause clubbing. And in the age the patients develop COPD, clubbing is most commonly caused by bronchogenic carcinoma. So if you find clubbing, it might be an ominous sign. A doctor should know this. So these are things a doctor should keep in mind for COPD while diagnosing COPD. Well, you have looked at the patient. Yeah, you have to look a little delicately and a little thoroughly. Now you look for pedal edema. It can be because of cor pulmonale, but it is non-specific. There may be many other causes of edema at this age. But keep in mind, edema from outside, looking at outside, that could be because of cor pulmonale. Raised JVP, well, it could be from cor pulmonale because of pulmonary hypertension. Pulse rate and saturation is very important. People do not bother to look at the pulse rate and saturation. I like to speak a whole session on pulse and saturation and the change of saturation in COPD because I have found that desaturation on exercise is very important. Pulse rate more than 100 or persistent tachycardia in COPD is not uncommon, and these patients essentially have diastolic dysfunction. 20 years back, diastolic dysfunction was not given any importance. 15 years ago, people used to say it is a problem of old age. 10 years back, people used to start talking, well, it may have an importance in COPD, and now it is very, very important. And diastolic dysfunction in COPD means there is a possibility of heart failure without reduction of cardiac output, heart failure with preserved ejection fraction. So if there is a persistent tachycardia, this is a very important sign. And if after exercise, the pulse rate return to normal pre-exercise state, or saturation return to normal to pre-exercise state is slow, that is also very important. And that can be judged by doing an exercise test, which we have evolved as a two-chair test. Since this is not the session for two-chair test, I'm not elaborating two-chair test, but this is a simple test. You make a person sit in a chair, on a chair, let him be comfortable, measure his pulse rate and saturation, ask him to go and sit to another chair, which is kept just 5 feet away, facing the first chair, and then sit, and you ask the patient to sit and immediately stand up and come back to sit again in the first chair. This makes one movement up and down. And such 5 movements are made continuously. Unless there is any difficulty, patient can stop. After that 5 movements, you just measure the pulse rate and saturation every 10 seconds for 2 minutes and plot them. We plot it regularly. We have got hundreds of patients with this record. We have published it, and this is integrated as a part of our usual practice. What I mean to say, this gives me an idea of recovery response, cardiopulmonary recovery response after exercise. This 5 movement in 2 chair is almost equivalent to walking for 6 minutes that we have seen. And we have compared the post-exercise recovery response of 2 chair test with that of 6-minute walk test. They are similar. This recovery response gives us enormous insight into the problems, and I can tell you it will be very, very useful for any of you who wish to practice respiratory medicine. I'm trying to work on it and publish it as I'm finding different diseases. Well, we have found that the COPD patients who have got a desaturation maximum, we call it desat max, from baseline to maximum desaturation, more than 3%, they have got essentially pulmonary hypertension. And these patients we have treated with vasodilators. That's a different chapter. I desire I can talk this in another Sky program, but for today it is important to impress you that two-chair test should be incorporated in your practice. It is very simple. It doesn't require a big space. And if you follow, you will be very happy to find the insight you get after using this test for a few couple of times. It will not take much incubation period to understand. Look at the flaps. Ask the patient to put the hand up and just see if there is flap. Flaps are present in carbon dioxide tension. The bounding pulse is also same. So let's just looking at the patient, the suffuse conjunctiva, slight dullness, flaps, touching the patient, the pulse is, bounding pulse. So you can have an idea the patient is retaining carbon dioxide. Then after looking all this, you look at the breath sounds. You may find wheeze. You may not find anything. Or most commonly, you can find reduced breath sound. If you look, if you note reduced breath sound, that means reduced air entry. That means essentially there is hyperinflation, there is air stacking, and the patient has to struggle hard to get breath in. And basically the air stacking occurs mostly in the lower part. So auscultation in the lower part of the lung gives you an idea whether the breath sound is really reduced because of low air entry. And that actually implies there is air stacking. In auscultation of the heart, we usually don't bother, but auscultation of the second heart sound is very important. And this is easy. If you're a little, vigilant, because the valves are quite close to the chest wall, you can listen to heart sound. First heart sound may be a little distant at times, but second heart sound is mostly audible. This is my experience. I've not done any study on that. You can find the liver little enlarged, but that enlargement may be because of the push down liver, or it may be because of congestion from cor pulmonale. So this is about understanding what a physician should know about seeing a patient. Let's come to the pathophysiology. On the left-hand side panel, this normal airway. On the right-hand side, COPD. You can see in COPD, there is excess mucus in the airways, the yellow color. In the right upper zone, there is destruction of the alveoli. There are basically two kinds of pathologies going on. One kind of pathology is hypersecretion, excess mucus secretions. The other kind of pathology is destruction of the alveolar wall. So whatever includes the destruction of the alveolar wall is basically peripheral pathology. And whatever actually causes hypersecretions basically is axial pathology. It occurs along the bronchial tree. And you know that goblet cells are absent or very sparse as we go down, and the respiratory bronchioles, they don't have goblet cells. So, or the secretion is less in the respiratory part, and the terminal bronchioles don't have these cells at all. So this is axial and peripheral, and you can see the lumen is compromised for that. In normal, the thickness of the lumen wall is much less than in COPD, where there is muscular is hypertrophy. And you can see how small is a lumen. Is a red one is a lumen, airway lumen. Here the lumen is irregular and it's a chink-like, and a lot of the lumen is all filled up with yellow secretions. So this is what happening in COPD, and there is airway narrowing. The same thing, but here something is extra. See, this is a small bronchiole, and these are the alveolar septi being attached to it. This tethering effects, this is like wheels of spokes of a wheel, and once the patient inspires, they actually draw and pull the airways away and increase the lumen. But what happens in COPD, because of destruction of the alveolar wall, these spokes are broken and they cannot actually increase the airway lumen in inspiration. Plus, this yellow thing is all mucus. There is mucus secretion filling up the lumen and making the lumen absolutely irregular. So you can see what happens in COPD. Naturally, you can understand what will happen. Coming back to the central response, with this physiology, there is hypersecretion, and hypersecretion is actually commonly associated with poor central response. Effort to maintain and increase ventilation to demand is active in good central response, but it is done and inactive in poor central response. There is carbon dioxide retention, and these patients are usually hypersecretors. They have got chronic bronchitis, and they are named as chronic bronchitis. They are called blue bloaters because of cyanosis. because they are not hypermetabolic, they are not breathing hard, they actually gain weight, they have a lot of edema, and they are bloated because of that edema and because of vasodilatation. On the contrary, those who have got a good response of the respiratory centers, they retain carbon dioxide late or even in the terminal phase. And they usually remain awake, conscious, alert. They show weight loss, they are cachectic, and they have got very strong feeling of dyspnea. But mostly we find a mixture. If you ask me by percentage, it is the mixture, the mixed variety is the most common. So it is wonderful. In one end, you find alveolar damage. In the other end, you've got the bronchial pathology. Both are COPD. Both develop from the same kind of insult. If you consider them separately, they are as if two separate diseases, but we call both of them as COPD. This is what I was talking. Here in this side, you can see the wall is thickened with hypertrophied mucous membrane, mucosa. And here its wall is clear, but you see the peripherally, the alveoli are destroyed. Multiple thousands and hundreds of alveoli are broken down into one big alveoli, basically reducing the surface area for gas transfer. And because of these big alveoli, there is an increase in the lung volume, but the total surface area for gaseous exchange is low. Increase in size, but poor in efficacy. This is what is emphysema. And here, the alveoli are now untouched. The small bronchi are thick with and blocked with secretions. There is no goblet cell here, but these secretions, the clog, the small bronchi, and as you go up, you can see this hypertrophy of the bronchial wall and mucus secretion is there all along. So if you do a bronchoscopy, you find the report showing that secretion is all over. There's thick secretion been cleared, etc., been written. This is quite common in chronic bronchitic variety of COPD. The same thing, I've taken this picture. It's drawn by Jabbar Al-Quitani from Egypt, now staying in US. It's given two appearances, blue bloater and pink puffer. I love this cartoon, so I have just added it. So what a doctor should know and look for. It is the possibly individual peculiarity that decides the course of a chronic bronchitis or emphysema. We don't have a control on it. We do not know much about it. And I didn't try to read on it before preparing for you. Let's come into pathophysiology, which is a little difficult. I'm not dealing in details. Basically, macrophages take a lot of charge in my role. They recruit neutrophils. Both macrophages and neutrophils, they release proteases. These proteases are different types, but serine protease, a matrix metalloproteinase, is a very important member. Actually, this protease is what they do. They digest protein. They digest the alveolar wall and destroy the alveolar wall. And these proteases are also important in mucus hypersecretion because they indirectly trigger the system. They also trigger mucosal inflammation. So there is alveolar wall disruption, mucus hypersecretion, and mucus inflammation, mucosal inflammations. Two things actually take part. One is oxidative stress, another is different proteinases. I've told about the proteinases, but oxidative stress, they are increased by noxious agents and lung inflammations. And both this oxidative stress and proteinase, they actually lead to COPD. There is intrinsic repair mechanism, but it fails, it overwhelms the intrinsic repair mechanism and leads to destruction. Here you can see the pathway. I'm not going into details. Here there are two phenomena been described. One is the protease. The proteases, they actually digest. In one way, they stimulate mucus secretions, they digest the alveolar wall, and there is other pathway which leads to fibrosis, peribronchial fibrosis. And this fibrosis, I told in the very beginning, leads to stiffening of the airways. So there is stiffening, there is alveolar destruction, there is mucus hypersecretions. The doctor should know and look for increased oxidative stress and protease activities are most important in the pathogenesis of COPD. Right now, in our status of understanding COPD, you don't have a ready-made test that you can measure the oxidative stress or protease activities. But I can tell you, researchers are going in the direction so that in future, maybe near future, we'll be able to identify individual patients, the protease activity status or the oxidative stress activity status. And that might help us to decide our algorithm of treatment. Since it is meant for the postgraduates, I have included that. This is a course of COPD. This is also very important. Every doctor should know. This card is very close to my heart. I tell my patients that, see, for everything, from birth to 25 years, we have our capacity been increased. We reach around 25 years, the height of our capacity. So it is implied to lung also. The lung function goes to the highest level at 20s. And then there is a plateau. I have not drawn the plateau well, but well, there is a plateau here. And it starts declining slowly and slowly and slowly. It declines and declines and declines. And declination goes on. But if you come at 50 years, it's pretty high, very good lung function. By 75 years, it is okay. And this dotted line is a line of survival. Suppose the lung function drops below the dotted line, means the patient won't be able to survive. So a patient reaches the dotted line beyond 100 years. This is the normal. If I am a non-smoker, if I've got no other insult on my lungs from any other things, and if I lead a so-called normal life, I am supposed to live 100 years with my lungs and more than that. But if a patient smokes, what happens? There is an accelerated decline of lung functions. And this decline is very fast. It depends. It can be here, it can be here, it can be here. So I have drawn it out here. And you see the end point is, say, around 60 years. So what was supposed to be at 100 plus has come down to 60 years. So COPD has caused reduction in lifespan. Life expectancy is reduced. And this everyone should understand. Unless we understand it, how can I tell my patients, well, if you smoke, and I draw this picture even on my prescription papers, and tell my patients, if you continue to smoke, this will happen. And if you stop smoking, the patient, when he has come to me, by age of 50, I know 52 or 53 or whatever, his lung function was supposed to be here, and his lung function is FEV1 is here. So I know that it is 60% of the predicted. I tell him, gentlemen, if you continue to smoke by another, say, 8 or 10 years, you will reach close to your terminal status. But if you stop smoking, then your lung function will fall much slower, and you will get a time. This is the end point, and this is the end point being shifted from here to here. So you'll get another 10, 12 years time on this earth. So please stop smoking. So this is extension of lifespan. So this is the normal course. This is the course of accelerated decline of lung function in smokers. And this is the course where the lung function declines tends to go parallel to the normal after cessation of smoking. This has been copied and acknowledge the source. The black is normal. The green is growth retarded. This is very important. This is very important because of genetic reasons and because of childhood infections. The lung function as such doesn't reach the right level in our youngsters, especially in the developing world, in socioeconomically poor countries. The childhood infection and different exposures actually retard the growth of the lung. So their lung growth is not normal. So this is normal. They have got lower lung function, but the decline of lung function is parallel to normal. Okay. This is the smokers. These are smokers. And once the smoker sleeps smoking, see, it has been up again and going parallel to this. And this is a growth retarded people. And if this is a growth retarded people, and if they smoke, they have the worst lung function decline. So if a youngster who is 18 year or 16-year-old has got a childhood tuberculosis or childhood pneumonia or childhood infection in the lung, already compromised growth of the lung, start smoking, he will have the worst kind of COPD. So this is also important. We do not keep in mind. We find a patient quite sick by early 50s or early 60s. We tell that, yeah, it is not going seemingly disproportionate. But if we take a history, in many of them, we find that there may be a history of pneumonia in childhood or history of tuberculosis in childhood. And this is quite common to my personal understanding. Well, this is what we should do. Our target will be that we should make such adjustment that if a patient has started smoking at any point of disease, despite smoking, we can push it up and we can, of course, stop smoking. So what a doctor should know: chronic noxious gaseous exposure leads to accelerated decline in lung function. The pace of decline is changed if the offending agent is withdrawn. That is very, very important. So we have to identify the offending agent, be it smoking, be it secondhand smoke, be it biomass smoke, be it pollution, be it anything else. Treatment of COPD should improve life expectancy. If I treat but cannot improve the life, that's not right. Well, any treatment should improve the life expectancy because I will change the natural decline of COPD better. So coming back to diagnosis, you have learned how the patient's present, but the diagnosis, in obvious suspicion, if you have a classical story, you suspect obviously the patient has got COPD, you then just ask the patient for a spirometry and look for any other differential diagnosis or any other thing. The diagnosis is obvious, but many a times COPD is not diagnosed early, which I've already told. In my practice, I have got early COPD been diagnosed just incidentally. Spirometry suggested from incidental chest X-ray finding or some HRCT finding, or done for some other reason, some tightness of chest, sometimes cough, sometimes patients willing to see what is the wrong, sometimes he cannot understand. And I'm very conservative in asking patients for spirometry, which I should not be. Because in private practice, we have to keep in mind the patient might misunderstand you. But in many occasions, I've found that even for trivial symptoms where I didn't suspect COPD, they have got early COPD. So that index of suspicion has to be changed, and that threshold for asking spirometry has to be changed. Spirometry is a very simple test, and spirometry gives you very, very important observations, which is really important. In incidental diagnosis, you have a presence of predisposition and symptoms. You do spirometry, but you have to look for clinical symptoms, chest X-ray, HRCT chest. Now, one can ask me what all investigations you are going to do in COPD. I think that can be dealt in another lecture, but these are the commonly been done. A chest X-ray and spirometry is common. Sometimes the patient are asked for chest X-ray, and in my practice, I do ask an echocardiography almost routinely in advanced COPD patients. Obvious changes are their clinical status, chest X-ray, spirometry, and if the FEV1 FVC by FVC is less than 0.7, that is a diagnostic criteria. So the diagnostic criteria for COPD in a suspected patients with the proper presence of predispositions and symptomatic background is FEV1 by FVC ratio and spirometry. Without spirometry, diagnosis of COPD is incomplete or undone. Previously, we used to look at the reversibility. Everyone knows what is reversibility. If you let the patient inhale salbutamol, wait for some time, ask the patient to give a blow and see the change in FEV1 if it is more than 200 ml and 12%. Then we used to say it reversibility. And reversibility was a marker to differentiate between asthma and COPD. From 2014 onwards, for different reasons, this reversibility criteria was withdrawn. Everything was put in the COPD basket. It was told that if there is reversibility of 400 ml and more than 15%, then it is possibly asthma. So asthma was given less importance. So that's a different chapter. In 2021, there has been a reconciliation, although not directly, but the FEV1 by FVC criteria is maintained, and the 200 ml and 12% reversibility is reinstated. So we are back to the previous understanding, which is fairly easy and to which we have been tuned to. And incidentally, the diagnosis of echo has been withdrawn. So from now onwards, it is not wise to diagnose echo. I'm sure the echo is there. Asthma COPD overlap is there, and it is there to stay. But I'm sure the echo definition is coming in a different form, because since echo is there and since the so-called echo, quote unquote, has been taken away, there is a vacuum to explain what is echo. And we are sure that some more acceptable definition of echo is going to come in near future. Coming to the spirometry, this is flow volume curve. So this is, you can see this is inspiration. So this is the point where from the patient start inspiring. This is at the bottom of the expiratory reserve volume, and this is at the bottom, at the tip of the inspiratory reserve volume. And this is expiration. This expiration goes, the flow increases first, then the flow starts falling, and finally reaches the baseline. So if you see, this is a flow. This is a flow. But because the residual volume is increased, the patient starts from here. The patient starts from here. This is inspiration. This is expiration. See, this is the total area under the flow. Here you can see the area is much reduced. The lung capacity is reduced. And here there is a coving up. This coving upwards shape is very important, and it reflects airflow limitations. So here there is a reduction in lung volume, lung capacity. There's increase in residual volume. There is obstruction. Here, the FEV1 by FVC is 0.56. Here, it is much lower because FEV1 is 1.8 and FVC is 3.2. Sorry, this is 0.56 for this. Actually, FEV1 by FVC is roughly 80%, 0.80. Don't look at the picture on the left side. Come to the picture on the right side. So this is called time volume curve. This is time, 1, 2, 3, 4, 5, 6. These are time in seconds. And this is volume. This is 1 liter, 2 liter, 3 liter, 4 liter, 5 liter. Well, the 5 liter is the vital capacity. Fine. The patient starts blowing. This is expiration. It should start from this point slightly. And he blows in 1 second. He has blown out 80%. So this is 4 liter. He has blown out in 1 second out of 5 liter. So FEV1, in 1 second, the volume being exhaled is FEV1. It is 0.4 liter. And the FVC is forced vital capacity, the final volume. This is 5 liters. 4 by 5 is 0.8. So the 0.8 is a normal ratio. So in this flow volume curve, there may be little bulge upwards in some young people. And this is a normal flow volume association where we can expect a flow volume, FEV1 FVC ratio of 0.8 or so. But here you can see this is scoped up. Everything is much smaller. The whole area is much small. So this is this, where there is a 40% air is exhaled in first second. So it is 40% means 2 liter out of 5 liter. This is 2 by 5. So what is 2 by 5? It is 0.4. So FEV1 by FVC is 0.4. Here it is 0.4. Here it is 0.8. So FEV1 by FVC ratio gives a diagnosis that this guy has got COPD. Some people have got a lot of arguments whether this value of FEV1 by FVC of 0.7 should be taken or it should be done with a lower limit of normal. Let the debate be there. We are not going into it. We are just taking these definitions. So this is the ex-smoker whom I have drawn. His lung function spirometry, expiratory time volume curve. He has cough, occasional worsening in winter months, shortness of breath and exertion, MRC3, mucoid expectoration plus, functional limitation mild to moderate. He's diabetic for 7 years. You can see that his FEV1 by FVC is 0.4. So it's COPD. This is reversibility. This is reversibility. If you give the salbutamol and see the reversibility, if it is less than 12% in 200 ml, you can say it is not reversible. What a doctor should know: clinical details and spirometry is essential for diagnosis of COPD. And do not bother for echo any longer. For the timing, do not bother for echo because the guideline has taken it away. Although we know echo is there. If a patient with allergic asthma has got a emphysematous lung, what would you say? It is echo. If a patient with asthma starts smoking and develops something extra on top of it, which is the telltale sign of COPD, like emphysema in HRCT chest, what did you say? It is echo. So there are situation echo is there, but for now we are not uttering the word echo. Well, once you have done that, next, to establish a diagnosis, everyone knows that you have to have a differential diagnosis. So you have to look at the differential diagnosis. And after that, you have to assess the COPD status. And that is not all. After that, you have to look for the comorbidities in COPD, and you have to look for the complications of COPD. These all points are important for a doctor to know and exercise. Let me start with the differential diagnosis. These are the common differential diagnoses: asthma, central airway obstruction, heart failure, bronchiectasis, tuberculosis, obliterative bronchiolitis. I think by frequency, it is okay to me in my practice. Heart failure is pretty common, especially we find diastolic heart failure, or what I told earlier, heart failure with preserved ejection fraction, pretty frequently in my COPD patients because they are mostly advanced. And I wish that I get an opportunity to interact with my audience with this particular diagnosis in COPD. This is also very close to my heart. Bronchiectasis is pretty common. 30 to 40% patients of COPD show bronchiectasis. Tuberculosis, well, tuberculosis has been thought of a etiology of COPD. It can be a concomitant diagnosis in COPD. And we have analyzed our patients where we find the odds for childhood in tuberculosis close to 2. So tuberculosis could be a possible etiology in COPD. Obliterative bronchiolitis is a very important diagnosis. It needs a high index of suspicion. Sometimes it mimics COPD, and it's very difficult because of air trapping. Everything goes very well, like emphysema and hyperinflation. But it is important. Diffuse pan-bronchiolitis, it is in fact rare in our country. I have not looked for any diagnosis of diffuse pan-bronchiolitis from India. It's basically a disease in Japan where the respiratory bronchioles are blocked with secretions. It's a and these patients have got concomitant sinusitis. They respond to long-term antibiotics. I'm aware of these conditions, but I have not diagnosed yet. Maybe I have missed possibilities there that we are also facing with diffuse pan-bronchiolitis. Well, once you see the differential diagnosis, then you have to assess the patient. A patient in front of you is suffering from a disease. You have got certain assessment parameters. Most of them are artificial parameters. If I see hemoglobin level, it is artificial. If I ask for FVC, this is artificial. If I ask for total lung volume, artificial. DLCO, artificial. I'm not going into discuss all this, but there are certain things which the patients have got his own individual feeling, individual assessment of the disease. This is patient-centric. It is not doctor-centric. It is patient-centric, and that's very important. And this patient-centric understanding is health status understanding of the quality of life, where multiple domains are included. This is a very, very simple test. We have a St. George's Respiratory Questionnaire, and that's a very good research tool, but it cannot be translated into practice. But this thing is very easy. This is called COPD Assessment Test, or CAT. There are 8 questions, and the answer is there from 0 to 5. 0 means none, not present, and 5 means extremely, extremely present, maximally present. Suppose I have no flames. My chest is full with flames, full of flames. So if it is full of flames, it is 5. I know flames is 0. Similarly, this 8 questions doesn't take much time. It has been my routine practice since I have started it, maybe 10 for 15 years. Dr. Paul Jones, the innovator or the creator of this, he came to Kolkata. He told me, you are my local representative. He later came to Pulmocare also in one occasion. And we follow all our patients with CAT CAT test. If you look at CAT, you can understand the status of the patient. You get a lot of insight. As I told, for 2 CHAT tests, it also implies to CAT, and it is accepted in research. Then you understand the degree of lung function change, and the parameter is FEV1. So this is gold grading of severity of airflow limitations. This is mild, moderate, severe, and very severe. If the FEV1 is less than 80%, it is, if more than 80% is mild, but the FEV1 by VC ratio has to be less than 0.07, 0.7. If it is moderate, it is less than 80%, but more than 50% is severe, less than 50%, and if it is very severe, less than 30%. This has been forwarded by Gold for quite some time. They have taken 2-3 things together into consideration. They have taken the Gold FEV1 reduction, the mild, moderate, severe, very severe. They have taken into exacerbation less than 2 or more than 2 exacerbation a year, and they have taken the health status, CAT score, and MMRC. MMRC 3 and 4 on the right side, CAT more than 10 on the right side. 10 is a cutoff point. So if a patient has got a low CAT score, good lung function, because lung function worsens as you go up, exacerbation increases, number of exacerbation per year goes up as you go up, and here CAT score goes more and more as you go to the right side. So this is how they have classified COPD into A, B, C, and D, although there are many lacunae about the A, B, C, and D classifications, but this is a way of understanding. If you have got 3 parameters here, FEV1, CAT score, and exacerbation, and if you've got 4 varieties, you can see how many phenotypes you can make out. So it is pretty complicated, and tomorrow such complicated things will come, perhaps more complicated things will come. Perhaps things will be like something which we'll have to use a computer to deal with. Maybe we'll be moving with a small apps in our hand. As soon as the patient comes, all the things will be put into the apps. It will give a phenotype calculation. It will give a sort of diagnosis. This phenotype, A102 phenotype, A302 phenotype, kind of that. I do not know what is going to happen in COPD or other diseases. Every disease is getting complicated. What I feel at this juncture of time, as a clinician, I'm a practitioner basically, that we must try to get things simplified. Everyone is trying to make the things more and more complicated, but very few people are trying to make it much easier. We should try to make it easier, and we should keep a basket for the complicated patient. We should drop all these complicated guys into that basket, and with the salutation refer them to a center which is meant to deal with those complicated cases. Otherwise, it is not possible for an individual practitioners to deal with too many diseases effectively. As a pulmonologist, I find that pulmonary medicine itself is turning like a sea. I've not been able to cope up with the developments, so I can imagine the status of a physician. He's really great. Anyway, to end, let me come to a patient of mine. This is arbitrarily drawn, but there is truth into it. Mr. SK is 59-year-old. His BMI is 18.2, so he's, vested. Ex-smoker for 20 cigarettes a day for 35 years. He's a diabetic, post-PTCA, hypertensive, hyperuricemic. They are on medications. Such a patient came to me only yesterday or day before yesterday, had 2 fractures in last 3 years, right wrist and left second metatarsal bone. So definitely he has got some problem with bone mineral density. Could be he's osteoporotic. History of exacerbation and hospitalization twice last year. And he's fed up with himself. He's short of breath for 5 years, progressive, and presently making him homebound. Actually, he is room-bound. He requires a lot of help for even dressing, undressing, not up to that level, but near to that. Cough with occasional streaks of blood for last 1 month, loss of appetite for last 2 months, feeling low, anxious, and disturbed sleep, having disturbed sleep for quite some time, and tingling of hands and feet. These are the presenting complaints. There are many other complaints. I've just jotted down only 5. So when I looked at him clinically, his pulse rate was high. He was sitting quietly. His accessory muscles were prominent. His breathing was paradoxical. JVP was looking raised to me, but the patient who is having very hard sternomastoid working, it is difficult to understand JVP. So I'm not sure. I said query raised, and saturation was barely 92% in room air. He was quietly sitting for maybe 5 minutes at my chamber. And I tried two chair tests. He had three movements. Sorry, I didn't mention it here. And his pulse rate went up from 108 to 132, and his saturation went down to 86. There was a 6% drop in saturation. It's a very significant drop. This DSAT max is 6. There was query clubbing, plus minus. Poor air entry both lungs. S2 was loud, and neurological examination was not done. He had tingling numbness. I should have at least looked at the jerks and the sensory things. I did. This is lung function in a nutshell. The FEV1 was post bronchodilator was 31%. There was hardly any good change, only 4.5%. The FVC was low. It was 45% predicted, and the FEV1 was barely 31% predicted. And the FEV1 by FVC was 40.35 post bronchodilator. So this is important. Every doctor should know that in a PFT, you have to look at the post bronchodilator value. I've seen many a times PFT has been done in different centers. They have given a pre-bronchodilator value that shows obstruction. They have written obstruction, but it is incomplete report. It is not an acceptable report. This patient had a CAT of 18, which is very high. He was MRC4, I have already explained, and he had more than 2 exacerbations already. So there's a diagnosis of COPD and etc. Let's come to the chest X-ray. The chest X-ray is, you can see it's a barrel-shaped, is a lung, and ribs are to some extent horizontal. The diaphragms have been flattened, and you can see the heart is not tubular. It is a non-tubular heart. It is like a normal heart. And if you look a little bit, there is something out here. There is something out here, and the right pulmonary artery, which looks quite dilated. So I can't see the left pulmonary artery. I can see the right pulmonary diameter. If it is definitely dilated, and there are certain ratios. If you can have multiple ratios been given, and to my experience, it is dilated. So I'm not going into, but this is a lacune in my practice that I cannot measure the ratios because of logistics. Further evaluations, HRCT was done. He had centrilobular emphysema both in the upper lobes, bilateral lower lobe cylindrical bronchiectasis. We had a lot of markings out here, and here bilateral cylindrical bronchiectasis, left paravertebral mass in the lower thorax. It was, to me, appearing as a neurogenic tumor. Anyway, features of PH was present. It was telltale in CT scan. I'm not going into details of it, but what I mean to impress that we have to look for all these in interpreting it, HRCT chest of a patient of COPD. What is the reason of asking HRCT in this patient? The reason of asking is manifold. One is that small opacity, which looked like a mass to me. Second is that pulmonary artery root dilatation. Third is increased bronchovascular markings and non-tubular heart. People say, okay, would you spend 5,000 rupees for this, or would you go straight away to echo Doppler? I say no, because I get a lot of informations, and I get this done subsidized, 1,500 rupees, 1,600 rupees from centers. So I do reporting myself, and this is my finding. I send the patient to the echo Doppler, and my friend has done, there was no regional wall motion abnormality of left ventricle. Ejection fraction was 54%, slightly lower, but normal. Grade 2 diastolic dysfunction. Pulmonary artery pressure was 54 millimeter mercury systolic. TRJ was 3.38, it is 3.40 almost, which is definite. Pulmonary hypertension, left ventricular filling pressure was more than 15. These are the criteria. I'm talking to my postgraduates and my physician friends. These are what I look for, and I would love to give a talk. What I look for in CT scan and what I look for in echo, and how do I interpret them, and how do I actually apply that interpretation in my practice. I would be loving to talk on that in future. But the other reports were there. His fasting sugar was 126. He was on anti-diabetic. Hemoglobin A1C was high, and his uric acid was 9.1. So this is also important. This is also important to me because well, I'll come to it later. The sugar is not controlled. Uric acid high means he's hypermetabolic, and he is prognostically, this is a prognostically bad parameter. So what is my diagnosis? My diagnosis, COPD, etiology smoking, predominant emphysema with associated bronchiectasis. I do not know the cause of bronchiectasis. Comorbidities, diabetes, hyperuricemia, hypertension, coronary artery disease post PTCA. Complications, sarcopenia because the BMI is low, osteoporosis because the fractures were there, pulmonary hypertension, which is obvious from both CT scan and echocardiography, and possibly heart failure with preserved ejection fraction. Why it is so? Because the left ventricular filling pressure is raised. But I have to go for a right heart catheterization in this patient. A lot more investigations are required. I'm not going into details. An incidental diagnosis, left paravertebral mass query neurogenic tumor. So this is a diagnosis of a COPD patient. I still feel that is inadequate and incomplete. I have missed anxiety neurosis or depression, which is very apparent in this patient. He has got disturbed sleep, he's in low. So that I should have mentioned. That's very important because that is also a bad prognostic marker. If a patient of COPD develops anxiety and depression, his life expectancy is definitely small. And this patient has got anxiety, depression, plus he has got hyperuricemia. So prognostically, he's a bad patient. So that kind of exercise is also required during making a diagnosis, which I have not mentioned. I apologize for that. So this is in a nutshell what is my diagnosis of COPD and what I feel my colleagues should exercise while making a diagnosis of COPD. With this, I'd like to thank you all. This is our first Sky program. Sky means skill and knowledge for youngsters. Everyone should try to make a complete diagnosis. We should evaluate the patient holistically. We should refer to appropriate specialists and to treat objectively. We'll be continuing Sky program from 12th onwards. Next month, we are going to have Pulmocon. In Pulmocon also, we'll be doing Sky program. And if God allows, the Sky program will continue. I'm looking for your support. I wish all of you join Pulmocon with great enthusiasm. I'm assuring that I'm trying to make the program very clinically relevant and also relevant to the time of our clinical practice. Thank you very much.
Sir. Hello?
Yes. Yes. Oh, অরিন্দম কর না, কেন করবি না? চেষ্টা কর। হ্যাঁ। So we can take up the questions later if any. Meanwhile, Arindam, if he's ready, he can present.
So you're audible, you share the screen, sir. Slides, sir.
What is the strength of the audience present now?
So 15 minutes back, it was 68.
Okay, let Arindam present. Arindam, please.
My topic was anatomy and physiology of airways. So this is a very interesting topic, and I have made the whole presentation for postgraduates. Some things that I was not knowing in my postgraduate days when I am doing MD in medicine, and I think all the people who are doing MD in medicine or CS or who are in the final year of MBBS should know this much about the anatomy and physiology of airways. That is only important thing that I have highlighted in my discussion. First, we come to the classification of airways. Very important. Airways first can be classified in upper airway, which is extrathoracic airway, and lower airway. Upper airway includes nose, nasal cavity, paranasal sinuses, and pharynx. Here it is. And lower airway contains the larynx and distal tracheobronchial tree. Hello, sir.
Yeah, we can hear you.
স্যার আপনারা এই ক্লাসিফিকেশন ও এয়ারওয়ে স্লাইডটা দেখছেন তো?
Slide, we are seeing a slide which shows different pressure, intrapleural, intra-airway pressure. The slide, I cannot see the classification of airway.
Sir?
Yeah, right, we can see.
So now the lower airway, the upper airway, and lower airway is divided by epiglottis, internally and thoracic inlet on the outer side. So proximal to epiglottis is the upper way, distal to epiglottis is the lower airway. That is the primary classification of airway. Now we go in a little detail. Airway can be divided in conducting zone, transit zone, and respiratory zone. Conducting zone starts from nose. That is from where this air comes in, and it continues up to the transit zone. There is no gas exchange which happens in the conducting zone. Transit zone is the place where these two things come in contact. And the last is the respiratory zone. That is the respiratory bronchioles up to the alveolar sac, which has the alveolar opening at the walls so that they can take part in the gas exchange. So conducting zone, transit zone, and respiratory zone. Now we come to the two more interesting topics, that is asinus and terminal respiratory units. Asinus starts with the transitional bronchiole, and it is just distal to the terminal bronchiole. That means asinus is the part of the airway which directly participates in gas exchange, and are better to call better to call it a terminal respiratory unit, which is not actually asinus, which is a unit consists of all the alveolar ducts together with the accompanying alveoli that came from the most proximal respiratory bronchiole, that is the first order respiratory bronchiole. And this terminal respiratory unit actually take part in respiratory gas exchange. Actually, 10 to 12 terminal respiratory unit are included in one asinus. So definition of asinus is liked by few of the people, and few people used to believe in terminal respiratory unit. But they are the ultimate airway zone which participate in respiratory gas exchange. Now we come to the upper airway anatomy. Upper airway anatomy is very important and very interesting, particularly in relation to the disease we know as obstructive sleep apnea. It has four parts. Nasopharynx, which starts from nares up to the heart valve. We can see here that this is the nasopharynx area, which is up to the heart. Then the retroparatal oropharynx that comes from the heart palate up to the caudal margin of the soft palate. So this is the retroparatal part of the oropharynx. And then below that, that is the retroglossal oropharynx. Just start from the caudal margin of the soft palate and up to the base of the epiglottis. This is the retroglossal part. This retroparatal and retroglossal part of the oropharynx are the narrowest part of the ear, and they are the most chance of obstruction are in these two places. Part of the upper ear. The hypopharynx is the lowest part of the upper airway, which is known as also laryngopharynx. It is the base of the tongue to larynx. That is laryngeal unit. This is the whole structure of upper airway. Now, upper airway boundary is very important because we can understand that it is basically a narrow orifice without any very strong bony outlet. Anteriorly, soft palatal comes, craniofacial bony tissue superiorly, parapharyngeal fat pads, pharyngeal constrictor muscles, lymphatic tissue, and mandibular rami laterally, and pharyngeal constrictor muscle posteriorly. So overall, there is no bony outline, and in these all soft tissues, they can put this upper airway in under pressure. Transmural positive pressure can be created by this tissue. And I have one to just show you the same thing with this CT scan. How the small the airway ultimately looks. So upper airway physiology, if we go to the upper airway physiology, there is collapsing factors and there is the dilatal muscle. Collapsing factors include the lack of continuous bony outline, external tissue pressure and negative inspiratory pressure transmitted to upper. Whereas pharyngeal dilator muscles, they try to dilate the muscle, particularly the genioglossus, and keep the upper airway open. When the balance is not there, the patient suffer from obstructive sleep apnea. And another part of upper airway physiology is that upper airway dimension changes during respiration and sleep. That we have to understand. At inspiration, it is relatively constant. At early expiration, it is dilated. The reason of dilation or early expiration is that the genioglossus muscle strength is highest at early expiration, and there is a positive airflow. So both the anatomically it is expanded and the muscles are at the highest strength. At the end expiration, as the airflow has diminished and the muscle power is also on meaning, that is the most time for most constriction of the upper airway, and at that time upper airway can collapse. Among the sleep, in REM there is a decreased dilator activity, whereas during the REM there is most critical for collapse because there is an inhibitory signal for the dilator activity. So a patient who has a borderline upper airway physiology and REM sleep in expiration can have a obstructive sleep episode. Neural control of this upper airway dimension is by hypoglossal nerve, which control the activity of genioglossus muscle. The respiratory control center also has inputs in this muscle, and there is a strongly excitatory influence of airway promoting neurotransmitter like endorphins. So overall, they maintain the balance in normal individuals. But all the individuals during sleep has a upper airway constriction. Whether that is more symptomatic, that depends on the pathogen. Now we come to the lower airway. And here comes the most important division, the large versus small airway. The large airways are the section of the airway tract that extend from medial subglottis to the end of large bronchi. And the small airways have internal diameter of less than 2 millimeters that occur at approximately generation 8 of the tracheobronchial tree. So from 8 to the rest, up to the alveolus tract is small airway, and ever proximal to it is large airway. Small airways are different from large airways as they lack cartilaginous support and mucous glands and have surfactant lining which reduces surface tension to prevent closure during expiration and low lung volume. These things are just opposite large airways. They have glands, cartilaginous support, but no surfactant. Transition from cartilaginous to non-cartilaginous airway is not happening. So transition from large to small airway is not happening. Cartilage amount of cartilage decreases gradually, and at the same time, new openings start to appear of alveoli. Depicted pictorially, there are the large airways and the lower, smaller airways, and we can understand how they are distributed. Usually, this tertiary bronchi is the end of the large airway, and after that, all the remaining airway generation and movement, small airway. Now we will have a look at the microscopic anatomy of large airway. First, the conducting epithelium. Very interesting. They have the goblet cells. They have the basement membrane and lamina propria. And they have this cilia. The cilia beat in the same direction at the rate of 10 to 20 hertz per second. And this beating ultimately propels the mucociliary layer so that the airway becomes more. So this is particularly present in large airways. As we go deep in the lung, the number of cilia and the number of goblet cells decreases. Goblet cells is the main secretor of the mucin. We will discuss it. Then come to the largest of the large airway, that is the trachea. And we have many glands, almost complete cartilaginous ring, and a trachealis muscle at the posterior wall, which basically constrict and give the airway a shape. Then we come to the bronchus. Here the cartilage are sparse. Glands are there, but definitely it is a transition from cartilaginous airway to the non-cartilaginous airway. And after the bronchus, we also get the smooth muscles here. After the bronchus, we come to bronchiole, particularly the terminal, just proximal to the terminal bronchiole. This kind of bronchiole you can see, where it is surrounded by epithelium and smooth muscle, but we are not finding any of the cartilages and glands. So these are the classical example of small airway. Surfactants can be found, and ultimately we come to the respiratory bronchiole. That is the part of the asinus or you can tell it as terminal respiratory unit, which is actually participating in air exchange. They start distal to terminal bronchiole. They have transitional bronchiole, which is a transition from terminal respiratory bronchiole, and their main components are respiratory bronchiole, alveolar sac, alveolar duct, and alveolar. They are the ultimate part of the airway system, which takes part in gases. We have a big discussion on airway glands that must be known by students. That is, mucin secreting glands are there, known as submucosal gland, which secrete MUC5D, and goblet cells, which secrete MUC5. MUC5D has a straight structure, MUC5A has a zigzag structure, and they are linked like a von Wieber factor with their C and E terminal, and make a long fiber of mucin, which ultimately helps in expelling the respiratory allergens and infections. And now we come to the cells in the airway. And among the cells, there are a lot of them. There are some common human airway cells like goblet cells, club cells, ciliated cells, vessels. And there are some cells which are not found over, like TAF, aerocyte, and the neuroendocrine cells. Among them, we have already told goblet cells, which are mucin secreting cells, which are more prominent in upper large airways and less in the small airways. Now we will want to discuss about pleural cells, which are more prominent on the distal airways and less prominent on the upper airways. They have apical granules, they are non-ciliated cells, and they are prominent in terminal airways, and they can produce surface cells, they can produce dense cells as well as other cells of the epithelium. So they are very important and significant part of respiratory epithelium. Now we come to large airway physiology. This is the another interesting part that should be understood by a student very much. It is a resistance, flow, and driving pressure equation by which the large airway actually works. The main work of large airway, there is many secondary work they do. The main work is to pass the air to the terminal respiratory unit so that gas exchange can happen, and also take out the air which is already been used. So airway resistance is contributed mostly from the upper air. If you do a nasal breathing, 50% of the total airway resistance is actually from the nose. But quiet mouth breathing, that gradually shifts towards more distal airways. Laminar versus turbulent airflow determines the resistance, and the Reynolds number that determines whether the flow is laminar or turbulent. What is Reynolds number? Reynolds number is the number for Newtonian fluid pressure formula. It is actually an equation between fluid dynamic viscosity, fluid density, and pipe diameter. And if this number is calculated in a straight, smooth, rigid fluid, turbulence occurs when the Reynolds number exceeds 2000. In human airway, laminar flow occurs only in small airways because they have enormous cross-sectional area, so flow is extremely slow, and this extremely slow flow actually can have a Reynolds number which is 2000 or less than 2000, so they can have a laminar flow. Otherwise, all the airways proximal to them have turbulent. Now we come, but this Reynolds number, apart from this Reynolds number, there are some other issues which actually plays in determining the driving force, which is the acceleration of air. The air, to go forward, air has to be accelerated. There is a local acceleration and there is a convective acceleration. For that also the pressure is needed. And when we put all these requirements together, we have a relationship between the required pressure, flow, and diameter. And this equation is known as Poisson's equation. This equation, everybody, we cannot memorize it. Everybody has to have an understanding that there is an equation called Poisson, which basically determines the relationship between this driving pressure, flow, diameter for laminar. And then comes the turbulence. As there is the absence of orderly pattern of gas movement, resistance to increases mass. It varies inversely with gas density as well to the fifth power of airway radius. So here it depends more on the diameter. Now we come effort independence of flow. That is the flow volume relationship. Flow is highest at the highest point. As the volume decreases, flow decreases. And after a certain volume, flow becomes effort independent. You cannot increase flow more. And this volume is equal to usually below 70% of the vital capacity. We have put a picture to show you that as it decreases the volume, the flow automatically decreases. And now we come to the most interesting part of this discussion, that is the equal pressure point. The explanation for effort independence of flow. First, we take a normal patient and we take a situation where the patient is forcibly exerted. So his pleural pressure is high, take it 20. His alveolar pressure is 25. Elastic recoil pressure is 5. This is 30. As the air moves towards the opening, that is the mouth, it loses air due to friction. It loses pressure due to friction. And this 30 pressure gradually increases to 50. When it becomes 50, the pleural pressure takes an upper hand and constricts the air. So that flow cannot increase any more after this point. So this is the equal pressure point. This equal pressure point happens in everybody. It depends on few features, like it depends on the volume of the air, lungs. As the volume is more, the distal equal pressure point move proximally. As the lung little volume, the volume decreases, it moves distal. This is called a volume, and we have shown this in three pictures that how the volume actually decreases. Because more volume, that means more alveolar pressure. That means it takes more time to get reduced due to the pleural pressure. That means the equal pressure point is moved forward. And if it is the equal pressure point moves with the cartilaginous airway, then the constriction is less and there is more air chances of air trapping is also less. But if we look the same thing in a COPD patient, then there is all the problems are there. The pleural pressure cannot get very high because of the diaphragm and the expanded muscle weakness. And at the same time, the alveolar pressure is also not very high. And due to the small airway pathologies, basically in a non-cartilaginous airway, the equal pressure point occurs. So it causes dynamic hyperinflation that causes air trapping. Because in cartilaginous airway, it can restrict the pleural pressure. It doesn't allow more flow, but it doesn't obstruct flow. But the same thing, if it occurs in non-cartilaginous airway, it can actually obstruct flow and cause air trapping. So this is an important physiological point for COPD patients. This can be explained in other two ways. One is known as wave speed theory, which says when fluid is pushed through a collapsible tube, the pressure wave is propagated along the wall of the tube. This is true for blood pressure also. The velocity of the fluid in the tube cannot exceed the velocity of the pressure wave. And the velocity of the wave represents the speed limit. Another way of explaining is Bernoulli's effect. If the tube is collapsible, as gas velocity increases, there is a tendency for the tube to collapse. So, reduction in air flow. This is another explanation how there could be a limit flow limitation. That is effort independence of flow. Now we have a small idea about small airway physiology. Resistance usually airway branches distal to the seventh generation, particularly small airways, constitute only 10 to 20% of total airway resistance. Because they have a huge cross-sectional area, so though their diameter is very little, but the flow through them is very slow. And as a laminar, as we have told earlier, this laminar slow flow doesn't allow to increase the resistance, as we have seen in various equations. Collapsibility of small airways counterbalanced by surfactant as well as tethering with the surrounding lung. Sarah has already told this loss of tethering is one of the main causes of this collapse of the small airways in diseases like COPD, and they participate in the gases. Like transitional molecule, onward small airways, they all participate in the small airways. That's all I want to discuss about this. And physiology of airways.
Thank you, Arinam. Thank you for the vivid presentation. There was some problem in the audio system. Sometimes it got a little disturbed. Anyway, I think we can take up questions if there is any right now. Abhijit, is there any question?
Just let me check, sir.
If not, we'll close.
So let's close that.
Then we can close, wrap up. ঠিক আছে? Is it okay? Hello, Abhijit.
Yes, sir, it is okay, sir. It is okay.
Thank you. Thank you. So thank you very much. I express my heartfelt gratitude to the audience and my organizing team and with Respira Lupin for supporting us. So let's hope our next session will be better. Thank you.
Thank you, sir.
Recording stopped.